to kick things off, I'm so excited to be able to welcome Jonathan Blum. John is our Principal Deputy Administrator and Chief Operating Officer at CMS. And in this dual role, John oversees CMS's program policy, planning and implementation, and day-to-day operations of the entire agency. He previously served at CMS from 2009 to 2014 as Deputy Administrator and Director of the Center of Medicare, leading the agency's Medicare payment and delivery reform strategies and the policy and management of the Medicare program. John brings an unbelievable 25 years with public and private sector experience, working in healthcare policy and administration. And in addition to his roles at CMS, if that wasn't enough, he has worked as a strategy and management consultant, as EVP for Medical Affairs at Care First Blue Cross Blue Shield, and professional staff on the Senate Finance Committee, where I was so fortunate to have met John there and remained in touch with him to benefit from him continuing to share his knowledge and expertise, and also continuing to come back to, not many people look to come for another stint at CMS, and so we're so fortunate that he did. Also, John served on many boards and several not-for-profits. So I just want to take a pause for us to thank John for joining us and how generous he is to give us his time. I mentioned as I introduced John that he obviously is in his current role as Principal Deputy Administrator and COO at CMS. And I know you've been there since the beginning of the administration, but just to sort of start in a reflective place of when you came in, John, what was your vision? And as you're here today, where do you feel the vision has been able to continue to be carried out, and what changes have already occurred in the agency during that time?
Sure. Well, thank you for the opportunity. It's good to see you again, Mary Beth, and it's always a pleasure to talk with you and your team here. But let's say a couple of observations just now coming into CMS second time. I think one of the things, the context was that we were really not coming out, but really in the depth to the COVID pandemic. And so I think one of the imperatives that we saw for CMS at the time was to really think about ways that we could build the programs to be far more resilient. And I think the observation that we still have today, is that those that really suffered the most during the pandemic were the ones that CMS serves. Those that have chronic conditions, those who have chronic kidney care, for example, those who are living within a nursing home. And so we really took back the step that our programs should really think about ways that we can keep populations healthier in the future, that we can build more resiliency to our programs, help support the healthcare systems, that when they have challenge or crisis, that there is much more support. So we took a hard look, for example, at all the flexibilities that CMS put out. And I think one of the things that the agency did during 2020 and 2021 was to really create new ideas, new innovations that really helped the healthcare system pivot to a much more flexible system. So that was kind of one, core strategy that I think today that we still have challenge, that we feel that we have much deeper connections to our public health partners. We have much deeper connections to the healthcare system so that we can release waivers, flexibilities much more nimbly. So that's one kind of area I think that the core focus starting in 2021. The second sort of observation too is that that our program scope now is so much bigger than it was, say, in 2009 when I joined the agency for the first time. We're covering more people. We're covering roughly half the population through CMS programs. A huge shift that folks here in this audience know better than I, that those programs are being delivered not through direct government reimbursement, but through delegation, partnership with managed care organizations, be it Medicare, Medicaid, or the growing marketplace. And so one of our core focus areas really is to think less about the silos for CMS and to think about creating just a much more common experience for those that we cover. And I think for all of us here in this room, for all of us really in our country, and all of us um, friends, neighbors, family, chances are that we're going to be covered by a CMS program several times during our lifetime due to change the circumstance, due to age, due to losing a job, pursuing brand new business, having a baby, dealing with a disabled child, for example. So the CMS that we want to create, I think all of us want to create for the future, is one that treats the patient, the beneficiary, really less in silos and more in a common experience. So we can really think about ways for us to think about kind of friction in the healthcare system differently, take away prior authorization friction, create more common systems. For example, we're making a pretty big bet that we can create one source of truth um, for provider information. So why should a health plan have to chase down the information separately? Can't we create kind of one common experience? I think the CMS of the future will be one that is much more focused on how we can create this much more common experiences, common systems, take away burden, take away friction, and really help the patient get access to care faster. The third thing, too, just an observation I just touched upon, is our programs, by policy design and by how beneficiaries choose to receive their care, for how people now have much more stronger incentives to receive their care through managed care organizations, means that CMS too has to pivot for how we really think about the organization, to our program, to our staffing, to our teams, to our budget. And so, for example, our program integrity dollars, roughly today, 90% get focused to how we run the traditional Medicare fee-for-service program. And so we're recognizing too throughout CMS operations, throughout CMS programs, that our work and our focus really has to evolve as the programs evolve. And so we're spending more time thinking about how we help support states run their programs, how we pivot our operations, focus teams for recognizing that, that to your reports findings, that more than half of those covered by the Medicare program receive their benefits not directly through traditional Medicare, but through a private managed care organization. So there is a same mission, today versus my first time at CMS, same beneficiary first focus, but recognition that our context has changed, our challenges have changed, and now that the country has decided that more than half of the population should be run through CMS programs in some form or fashion, which will probably grow over time, proportion and people, creates a whole new opportunity for us to reimagine the patient experience, the provider experience, the care experience, but how we think about our programs, lessen those silos, and more about delivering healthcare benefits to a population, no matter what life cycle or choice they're making for how to receive those benefits.
Thank you, John. And just as you talk about the different changes that have occurred, and you referenced the work COVID, can you, because you were in this role during just an unbelievably historic time for the country, what changes occurred because of COVID that you see as being either permanent or temporary? And some of the examples that come to mind is, were we talking as much about isolation now if there hadn't been a COVID, or also just the awareness of telehealth?
Yeah.
So just from where you lead the agency, where do you see some of those changes being permanent?
Yeah, I think a couple of, just kind of broader themes, and I think just some kind of overall legacies that I think will be durable throughout time. One is the partnership sort of foundation that was created during COVID for how we work better together. Things like how we communicate need, how we respond to need. And I think one thing that we're doing more in the eternal frame is being much more cognizant to how we recognize challenge throughout the country, respond to that challenge, and be able to provide the resources towards that. Let's just take cybersecurity challenge, kind of one example. I mean, we saw this year that the agency really had to step up to help support the healthcare system when Change Healthcare happened. That's an example for the infrastructure that we built during COVID that wasn't perfectly nimble, but far more nimble than it could have been had we not had that experience. So I think going forward, public policy, CMS, government will be there to support the healthcare system during times of challenge. I think that's one durable legacy. How we think about the most vulnerable populations and circumstances that they live in. And so all of us were horrified. The stories, the family members, the fear that people have who are isolated within a nursing home context or similar kind of care setting, home setting. So going forward, we have spent much more time, resource, and focus for how we to ensure a safer nursing home environment, for example, to make sure that we are really focusing on how they staff and they run their operations and how we do the oversight differently, and also provide the support to those that are trying to do the right thing. Third legacy, I think, is that the COVID pandemic in 2020, 21, and 22 really forced us in the healthcare system to really reimagine how healthcare services could be delivered differently. Telemedicine, for example, and hospital at home, that I think will be, things that will continue to evolve. But I think there is growing confidence within our environments that these services can be performed high quality, without fraud risk, without safety risk. And I think that will be a much more durable legacy going forward. And I think the challenge, particularly with telemedicine, particularly with hospital at home, is that they're running through our sort of CMS legal framework, which says that providers have the right to bill for these services. And that's a very good thing, particularly when it's done well. It's done in coordination with other services. There's good controls for fraud, waste, and abuse. But that's a different statement than saying patients have the right to these services. So I think that's really the next, kind of vanguard, the next innovation, to support the emerging side of care changes that our healthcare system has built. But we're in a frame that's in the traditional Medicare fee-for-service frame of providers have the right to bill for these services. And again, that is far different from saying that beneficiaries covered by our programs have the right to access those services. And I think that's the next place that policy needs to go.
Thank you. Again, as in the role that you were in now, but also when you were the head of Medicare, since then there's been the growth in Medicare Advantage and ACOs. And if you can just sort of share your thoughts on the future of both those programs, and especially as we already have recognized from the report the growth of MA, but also with ACOs continue to expand and attention needs to be brought there.
I mean, it's really a kind of great question. And I think the CMS framework that we have today, and I think it's been the CMS framework for, going back in time, is that we're not necessarily going to tip the scales of pushing beneficiaries to one choice versus the other. But there are differences throughout the programs that really affect how beneficiaries make the choice processes going forward. And I think one of the value propositions that the ACO program provides to traditional Medicare is to really to instill the same principles, the same focus, the care coordination demands, and the kind of accountable care demands that we have for all patients, to really bring that to the traditional fee-for-service program. But the MA program, in its current frame and focus, has so much more flexibility to offer the supplemental benefits, the infrastructure that a health plan can bring relative to an ACO. So that's going to be, I think, a tension and a balance that continues to play itself out. Kind of one thing that our teams really did well starting in 2021, I'll give credit to our teams for this, was really to set some bold goals for how we think about what care should be, particularly within the Medicare program, but also within Medicaid too. That says that 100%, and this is our North Star, of those covered by our program should be in an accountable care program. And then you have to ask the question, what is accountable care? How do we define it? What does it mean? And I'm sure everyone in this room would probably answer that question differently. So I do think we need to spend more time, both in our ACO programs, but also in the MA program, to really drive towards the question, what is the expectation that all of us would want ourselves to receive, that our parents to receive, and our children to receive. And I think that needs much more definition going forward. And then we can build the policy designs, we can build the program structures, we can recommend changes to the Congress to really drive towards that. But I do think we need to recognize that while we have this principle within CMS today is that we're going to make sure that people have the right to choose, whether it's the MA program or traditional Medicare. There's just some inherent differences that really challenge that sort of kind of fundamental balance today.
Well, and so appreciate the leadership that you all have at the agency on ensuring that seniors have that right to choose. Um, I had spoken earlier about just where we're at with the various policy changes, but fiscal pressures, aging population that have put pressure on the Medicare Advantage program. And so, on the theme of stability, how do you see it looking ahead, ensuring there's stability? And again, not just for Medicare Advantage, but other aspects of the Medicare program.
I mean, I think one of the things that we see, I mean, I'll share a couple examples
Mhm.
from travel. So I've been spending a fair amount of my time getting out of DC World, getting out of Baltimore World, going into our 10 regional offices, really to better understand how the CMS programs are working and how they're kind of shaping healthcare really at the local level. And those trips and those stories that come out of it, I think really, for me personally, kind of help shape thinking going forward. One of the things that we see, and I'll give an example of this, is just how complex the CMS programs really have become. And I think it's an area that we need to spend more time thinking about. For example, uh, we were in Washington State. We were touring rural healthcare hospitals, and so our team. This was during this time last year. I guess it was in November or so. We were building in the thick of the Medicare season, and so our team wanted to do a drive-by of a local SHIP center, a senior center, to thank the volunteers, really talk to Medicare patients. We pull up to the senior center, and there was a line out the door, and they were overwhelmed. And so the poor woman who was running the senior center came to us and said, "Please leave. Do not come in. You're too disruptive." And I think the thing that we saw in the people who were there to see the SHIP counselors was there was fear in their eyes. They were worried not to have time. They were worried that they wouldn't get the access to that counsel. And I think what I saw, and debate whether this is happening throughout the country, is there is so much complexity to our program, so much choices now that are driven through the marketplace, that the end result really is this fear that those individuals who are standing in line, needing help, needing assistance, and worried that they weren't going to get time with a SHIP counselor because they were worried to make the wrong choice. And so I do think one of the imperatives for all of us to think about going forward is how we bring more simplicity to our programs. And maybe we're going to have competition. That's going to be something that's just an enduring legacy, and there's going to be lots of planned choices. But then how do we ask the next question of how do we take away the fear, take away the worry, take away that, given all the marketing that's being pushed through the system, that the individuals who are at that senior center were worried they were going to make the wrong choice. The SHIP volunteers who were there did not have time to serve the demand that was present that day that we drove by. And I think that's one of the imperatives that we see going forward, is take away the worry, take away the fear that somebody may make the wrong choice, and therefore the spouse, the parent won't get access to the healthcare services that he or she may need in the future. I think that's one imperative going forward. A second imperative that I know that you're hearing, that we're all hearing, is there is just a lot of provider plan friction right now happening in the world. And I know there's different takes and different sides and different perspectives. But what we hear is the degree to which a rural hospital, for
Mhm.
example, has to spend time, resource of navigating prior authorizations, care denials. And so it seems to us there's also an imperative that we think hard, not to take away a plan's rights to set the best clinical medical policy. That's what a plan is supposed to do. That's the value proposition that that is provided. But at the same time, that we do so in a way that takes away the burden, takes away the friction, delivers the right care to the right patient at the right time, and not picking a side, but there is a lot of anger right now within the provider communities for how they're experiencing the CMS programs, and that's an area I think requires urgent attention.
And just on that theme, both the providers, but then those in the rural areas, is there anything, that you would be asking? I know you sort of touched on some thematic areas, but, asking the plans
Yeah.
to do, better. And, I know we talked about the complexity for seniors with prior auth and BMA support there, but I know that there's so much more that as you're giving these themes of trying to be more of a, partner with the provider community, especially in rural areas.
I would encourage everybody in this room and everybody that cares about the CMS programs, the Medicare program, to travel to rural parts of our country and really understand the experience that is happening. What we hear from those that are running systems, if they say, we have a great contract discussion with our plan partners, the contract gets signed, the terms are then fair, and then they say, but when the contract's carried out, that the terms don't get followed. And so somewhere between signing the contract to set the rates and all the things that a plan and a provider system do to come to an agreement don't get carried out during the year. And again, I'm not saying that's true or not, we don't have insight to that, but that's what we hear. The second question that the first question is, why does that happen? Where's the disconnect between contract terms getting signed to the experience that a care system receives during the year, and kind of where does that disconnect? So really trying to dig into that. Second question I would encourage folks to ask when you're talking to a hospital CEO or the head of nursing or the head of provider billing is, would you sign up for a Medicare plan product? Would you ask your spouse to sign up? Would you ask your child to think about, or your neighbor to think about the MA program? And at least from those folks running the system, I would bet that 95% would say no. They would much prefer traditional Medicare. And so there is an imperative, I think, to convince those that are running health systems, provider systems. I think it's being felt really acute within the rural communities, not necessarily just rural, really to understand that question, because what we hear is the traditional Medicare system works better, the claims get paid faster, it doesn't require all of the back and forth. And comparing pre and post time at CMS, that 2009, 2014, we've heard the complete opposite. People will say the MA program pays faster, pays better, pays quicker, and those dynamics really have flipped. And so I would encourage the plan community to really get out to that kind of audience, ask those two questions. What is creating the disconnect? And then two, would you yourself choose to receive your Medicare benefits within an MA plan? And the answers might be surprising.
No, well, and for those of you who are here today and tomorrow, we do have a panel
Good.
focusing on rural health. So John's done a bit of a teaser for us
Right.
here.
You're going to hear a lot.
And and also what ideas we may have. We're approaching open enrollment, and so this is a really important time to, as you're talking about, just trying to eliminate complexities for seniors. And an area where CMS has shown leadership is addressing some of the marketing issues. And when I spoke earlier about BMA trying to bring solutions and improvements to the program, there's some areas in the marketing where we've been mutually aligned. But there have been some recent changes focused on the agent broker compensation and also just promoting some objectiveness in the marketing recommendations, and they've been put on hold. So if you can just speak to what you're trying to do there and just what we need to do to bring confidence and trust back in for beneficiaries being able to work with the agent brokers, where there's so many who really depend on that relationship and how they choose care.
I mean, one of the questions that I talk to health plan executives about that work in CMS programs and get their perspective on why we do have so much marketing friction, complaints coming at CMS. And I think the response is that the sales channels that are operated really are just not a preferred approach, but a necessary approach for how products get sold. And I think you asked the question, well, how many of your sales come through kind of agent broker channels? And they would probably say 90–95%. And so I think we have to recognize that, that in today's world, that the agent broker relationship is critical for how these programs grow and how members find products. The counter to that sort of thought process is, from our vantage point, complaint volumes are at really record highs, not just on a total volume perspective, but on a per beneficiary perspective. So we're doing a lot of work that's really direct engagement with plans to say, this is your complaint volume, this is a challenge. Let's figure out ways to get that down. So I think that is just out there. The second thing that we hear from brokers, but also from beneficiaries, is just the intense marketing that happens and the incentive to compete for the member, to steal the broker's relationships. And I think going back to this first notion, that our goal should be to simplify the program, make it easy, make it less fearful to choose the right plan, the right product, the right way to receive your Medicare benefits. I do think we need to reset the relationships throughout, that we come back to that first principle, that programs work to help simplify the experience for those being covered. And then lastly, I think the thing that we think a lot about lately is there is so much competition right now regarding supplemental benefits. And that really is how we see the advertisements now on television of the more innovations to our program, which are positive. I don't want to dismiss that, but that's how the programs really are being marketed, the intensity for joining one plan versus the other, because one plan's offering $25 more for the over-the-counter gift, card benefit relative to competition. But could we instead begin to work together on ways to shift the marketing towards that? If you join this plan versus that plan, if you join the MA program versus a traditional Medicare program with ACO, you're going to get a better healthcare result. You're going to get a better outcome. You're going to stay healthier. And I think the star rating system really has that purpose built into it, to shift how we think about the program towards the outcomes, the quality care measure that we care most deeply about. But I think the challenge that we see right now is that marketing, the focus really is around the supplemental benefits, while there's a lot of friction happening within the care delivery network space. But I think the goals that we all probably have together is to really shift the focus, to shift the marketing, get back to basics of the value proposition of having a much more integrated product, a much more care managed product, much more curated care network product, is that better outcome for the patient. And that really, I think, has been the theme, the focus to our work, and ones that I think we can all work together on to achieve better results for those that we care about.
Thank you. We're seeing that seniors turning 65 are continuing to, work, past that age, and so there's a need for sort of an evolution of services to meet that population. And so, if you can just speak to where you see policy development either happening or needing to happen for those in Medicare Part A and the EGWIPs, across both Medicare Advantage and Part D.
I think this trend calls for the need for greater investment, for greater resource, for how we begin to prepare Medicare beneficiaries earlier for the choice process, for the care delivery choice that they're going to have to think about in the future. And so one of the things that we debate within CMS, and our communications folks tell us, well, you really need to capture the beneficiary 2 to 3 months before they need to make their decision. That's, people don't pay attention to their benefits, to the advertisement. That really is the peak time now, basically in the calendar, to get people ready to make that change. But I think one of the dynamics too, particularly as people think about delaying retirement or working longer, or thinking about different or starting their own business before they go into full retirement is their healthcare kind of decisions can get factored into those choices. And so we collectively, I think, need to do better to really begin to prepare people when they're 62, 63, 64, going into 65 or later, to really understand the choices, the decisions, getting back to that complexity. When they do become eligible for full Medicare benefits, they'll probably face a lot of different choices, a lot of complexity. And I think that's, going back to our earlier theme, that really is an imperative for the future.
Thank you. So I've been fortunate to be able to have the time to ask John these questions. So one more question,
Yep.
and then we want to open it up to the group. And again, thank you so much, John, for offering to do that. But the one issue I want to close on, which I know is an issue important to all of us, and CMS has shown so much leadership here, is in health equity. And as we continue to prioritize that area, and again, a policy solution that BMA is focused on, but there's just so much more that needs to be done. How do you see that evolving in the agency's work, and what would you be, asking of the Medicare Advantage community today to be doing more?
Yeah. I think we've done well collectively to better understand the disparities that we have in our healthcare systems, um, the the root causes, the sources to those disparities, and I think we've done a lot together to really garner focus, garner attention for bringing healthcare equity. It really is the first pillar for CMS work to the forefront. We've made more investments for how we build data capabilities so we can see the more granular areas of our healthcare system where we have a fundamental challenge. Where I think we are going next with CMS work is to really build the policy response to how we address those gaps in care, for example. So I think in version kind of 1.0 and 2.0 really has been to frame the problem, define the problem, begin to set the course to address that policy challenge. But I think the much harder work going forward will be to really make choices for how we choose to set policy priorities, to get very tactical. We're starting to do this, for example, within our star rating systems and our innovation center models for how we begin to build payment design that begins to address some of these care gap challenges. But that really is, I think, the next vanguard for all of us together, is to really set priorities for policy response, think through what the policy mechanisms are. So in version 3.0 of our healthcare common agenda together, I think that's the next phase to our work.
Thank you. So much more to do. All right, we're going to turn to all of you for questions. So, Tom, I think what we're doing is, if folks have questions, and Jeff, we already have you leading the charge, just go up to the mics and just please introduce yourself and the organization that you're with. We don't want anyone shy here.
I want to move a step down from the care, really to full risk physician groups and access. And really, I think part of the challenge has been some of the policy changes have made major reductions in revenue. And while on average you might say it should be relatively modest, it's a skewed adjustment. And for those who were early adopters and leaders into the full risk world, there's been an outside negative impact on revenue. At the same time, expenses have been increasing. And I'll tell you that we understand our business well. The way our business runs is we would have a margin on our existing patients, would use that margin to fund new patients on whom we know we will lose money. So I've talked to about 35 full risk groups around the country. 100% of us have committed to no growth for the next 3 years. We will not accept any new patients. So how do you then drive access from physician groups if the physicians who've been leading the charge for full risk Medicare Advantage based care for patients won't take new patients? Sorry for the challenge to the question.
I mean, I hear the question, can appreciate it. um, we feel confident there is more than enough resource in our healthcare system, the programs that we have today to ensure strong access of care. We don't necessarily distribute those dollars well. And so I think that is one of the kind of fundamental challenges for the agency, for our programs going forward, to really take the resources that we have and to set policies that will distribute them much more fairly throughout our healthcare system. Just speaking for CMS, for example, we are building our programs recognizing that we're in a period of relative fiscal constraint, and that we're going to have to do more with the same resource that we have today. So we feel confident that our programs will have more than enough resource collectively for us to serve the needs for those covered by the Medicare program. And then I think the challenge always is how you set the payment policies and how you set the reimbursement frameworks to ensure that there's fairness throughout the system, and there's equity throughout the healthcare system. Happy to talk more, but we feel confident of that going forward.
Hi, good morning. I'm Rich Brennan. I'm the Vice President of Federal Affairs with the ALS Association. And thinking about, first of all, thank you for your comments as far as reducing friction as we come to a point in time where people do have to make decisions on their Medicare. People living with ALS are, because of their disability, have the opportunity to receive Medicare benefits. But in many respects, those decisions are based on whether or not they're going to receive the care that they need. They have a terminal illness, and actually, in relatively from 2 to 5 years, go through every conceivable program that Medicare has to offer, and Medicare Advantage. What kind of, as far as in thinking about the disability community and those that are in terminal illness situations, those that are relying on their family members to help with their care, how does necessarily Medicare Advantage work best for them? If you can please address that. Thank you.
I think all of us together need to, I think, better understand how we probably mistakenly create friction in the healthcare system. And I don't think anybody in CMS world, nor do I think anybody that's running a healthcare plan or operation or health system wants to deny care to the patients that most need care, that are most dependent to our programs. But I think we collectively think about the day-to-day operations that create friction. We put in place prior authorization policies that we probably think make sense from a business perspective, but don't make sense for the human perspective. And so I do think a lot more work collectively, not just in the MA program, but also in the Medicare fee-for-service program, to really take a hard look and make smarter choices and come to greater consensus of when does it make sense for us to create a well-designed medical management program versus when do you really want to defer to the physician, the patient, to make the choices that are best designed for that circumstance. And from my time at Care First, you could look at data and say, of course we should put in place more medical management policies. But then when you really talk to the patient, talk to the physicians, did the sort of post-payment review, did it make sense for the physician to order that medicine at the right time? The answer generally was yes. And so that is my personal learning, that it's very easy for us to say, well, looking at the population, that you can put in place this policy, but you get down to sort of that individual choice, then it doesn't make sense at all. And I think we need to come to much greater consensus of how we design these programs and place greater emphasis really at the physician-patient relationship than we currently do. And that's another area that we need a lot more work on.
Thank you. Why don't we shift over here? Thank you.
Yeah, hi, good morning. Thanks for joining us. I'm Clara Keene with the Healthcare Leadership Council. And I just appreciate some ideas that you shared with BMA allies of how we can help you. I'm really focused on that building trust between providers and plans. We have both well represented in our association, our membership, so we're really focused on that and good tips on having those conversations and looking at contracts. We have a work group that we put together to focus on just that, and we have some common principles. So I'm interested in any advice you have or how you see the path for building that trust and moving forward. We've certainly engaged on some of the data seeking that CMS is doing to learn more about Medicare Advantage data, but I'm interested in any more tips you have or how you see that path.
Um, yeah, I think it's great. I mean, I'm very glad to hear that there's focus and really emphasis of better understanding both perspectives, because I do think the patient, the family is getting caught in the middle sometimes, or not sometimes, but fairly often. I said it previously. Best advice would be to get into the field and really understand some of the challenges that are being faced of health systems that are struggling, not just in rural areas, but in uh, isolated urban areas, and to really understand what's happening, why is it happening, what's causing friction. And I think our lesson is that we've got to really better understand that friction points better. We have to dig into what's creating it, and then I think, but for us collectively at CMS, it's been super helpful to get out of this town, get more into the communities that are facing the most challenge. We just started this project that our Innovation Center team has done to engage communities directly, to define the challenges, to build the solutions. And it's been really helpful for us to just get deeper perspective to what's causing some of the challenges that you're describing.
Hi, David Moeller from Capstone. You alluded earlier to the 2025 rulemaking around agent and broker compensation. And I'm curious, just given the, I think, variability of contracting models within the agent and broker world, was there a particular focus on, e-brokers or FMOs, or one kind of model you had in mind with that? And any thoughts there?
I think you're asking me a question. I need to defer to our teams. They're far more familiar than I am just to those rules. I'll have to defer that one politely, but thank you for the question.
Hi, I'm Philo Hall with Epstein, Becker & Green. I'm wearing a few hats, but one of them is working for Jeff, so I'll ask sort of a follow-up question from him. You stated that you believe there's enough resources in the system to meet access and the promise of MA or promise of quality outcomes, quality care for beneficiaries. And I want to go back to the MA data RFI earlier this year, which teed up a lot of interesting questions about what Jeff was raising about the extent of value-based providers operating under MA, and then what are the extent, how should we understand the impact on those providers or others when there's increases or decreases in MA payments. And it also keyed up some very interesting questions about supplemental benefits, the cash cards. I think a lot of those questions could lead to certainly a more shared understanding, a shared belief about like what are the impacts on services and access to those special advanced primary care services for beneficiaries if some of those questions are followed through on. So I guess my question is, what are the next steps following that RFI, and hopefully what more can CMS do to sort of shine a light and have some shared understanding about the extent of value-based contracting in MA and its unique impacts?
Yeah, that's a great question. I appreciate it. One of the things, again, this goes credit to our teams, that we are doing more of is to seek input from those that provide services to beneficiaries. And so the RFI process that we've done a couple of these in the past several years really is part of that overall strategy. So I would say the RFI that we released recently was based upon kind of fundamental curiosity for how we can better run CMS programs going forward, and do so in a way that's transparent, and do so in a way that brings in thoughts and ideas from those that we work with, those that we partner with. We CMS cannot see in our data, I don't believe we can see which providers have risk-based contract with health plans. Those are private, relationships, and so we have curiosity of, do we get better outcomes for our beneficiaries when plans begin to engage in those kinds of relationships? Not knowable in our data today, but can we work collectively to better understand that question? So, that you can kind of say with greater confidence that when a health plan does go into that kind of contract relationship, the care experience is better from the beneficiary. I'm sure you have your own clinical data to demonstrate that at a population health level, we don't have insight to that, but we have genuine curiosity to that. 1.2 that I think we're all aware of is that the level of dollars going to supplemental rebates continues to climb over time. And so why is that? And why is supplemental rebate dollars growing while network conflict seems to also be growing? And so the questions that we're trying to better understand is, how do we think about the relationships between growth, dramatic growth in supplemental benefits? Meanwhile, we see a lot of, or hear about a lot of friction between plans providers. And so how do we make sense of that? And I think that's another sort of theme to the RFI that we're really trying to better understand, is as we see this growth in supplemental benefits, how is it impacting the core benefits that a plan is obligated to provide beneficiaries? And there is a lot of curiosity to that. Not sure I answered your question, but I'll do my best with those two responses.
Okay, one quick question, because, okay.
With the Chris Meekins, Raymond James, with the Supreme Court's decisions in Loper overturning Chevron, as well as Ohio versus CPA and all the adjustments that'll make with regard to comments that come in, how is that impacting CMS's policymaking and what they may do approaching changes you outlined, potentially wanting to make going forward?
I would think it's a great question. I am totally out of my lane, not being a lawyer, to respond to that question. But I think it's one that I think will continue to play out, and we'll defer to our legal teams to give you a far better answer to that question than I can. But thank you for the question.
Thank you.
All right, thank you.
John, thank you so much. And I know many of us have the opportunity to work with John and know the demands in his time. And just for you to be able to be here today and both generous with your time, but also your candid insight, and just giving us some ideas, opportunities to be, hopefully an even more effective partner with the agency on improving Medicare Advantage. So just thank you.
Thank you.